Hello and welcome to your Chapter 11 video lecture where we are going to talk about cancer biology. Naturally, we first have to define what cancer is, and so it's kind of like an umbrella term that discusses diseases in which we're going to see these abnormal cells that will divide uncontrollably and will start to invade other tissues. So you can see that we've got different types or different paths in which this happens. We'll talk about that a little bit more on the next slide, but the word cancer actually is derived from the Greek word for crab, which is carcinoma. Notice the oma ending here. And so that got me thinking, why did they have the crab symbol for cancer, the zodiac sign? And it turns out that with it being Greek, and meaning crab here, it's going to be related to the crab in Greek mythology that pinched Hercules when he was fighting Hydra. So that's kind of how that came to be. We know now through astrology that the remains were then placed in the sky by Hera, and that formed the Cancer constellation. But as far as the disease goes, the reason they called it cancer is because when we saw these growths here, they are going to have these outstretched areas where the cancer cells kind of look like little crabs. And I'll show you a better representation of this in several slides from now. But you can also even see as the cells are coming together, especially when something is malignant, you can see that it kind of stretches out almost like crab legs too. So anytime we have a type of growth like that is rapid and uncontrolled, we are going to call that a neoplasm. So it is a new growth. And what we're seeing here as an example of that is a colectomy specimen in which we see a malignant neoplasm, and it is invasive and a piece of colorectal cancer. So we see this crater-like reddish irregular shape that the tumor is presenting. And so you might be wondering from this previous slide here, what's the difference between a benign tumor and a malignant tumor? So when we have something benign, it grows slowly and it really has this capsule around it that keeps the cells almost in a ball-like fashion, but it doesn't necessarily have to be round. And it is not invasive into other tissues. It's well differentiated and it has a low mitotic index, meaning the cells are dividing, but it's a little bit on the slower end, and it does not metastasize. It is not traveling to a secondary site. Whereas if it is malignant, we're going to see rapid growth. There is no capsule, which allows it to be invasive and move into other tissues. It's poorly differentiated and has high mitotic index, meaning it is rapidly and very quickly dividing. And so it can spread into distant areas, secondary locations. It can gain access into our cardiovascular and lymphatic systems so that it can travel and kind of take resident in other areas to spread. So we'll focus first on the benign tumors. These were named according to the tissues in which they first arise from. And by first arise from, I mean, what was the origin or the normal cell type within that area? So you may have heard of these terms before. First, we have lymphoma. So we've got the lipid cells here that become cancerous, and we can see that there is a lump here of an example of a lymphoma on the shoulder. Then we have a leiomyoma, which is going to be a tumor that develops in the smooth muscle of the uterus. And you could see that this can really happen in many different places here. We have it intramural, where it's kind of right within the body of the smooth muscle tissue here in the myometrium, if you remember that name. Submucosal, closer to where that endometrium location is. And it can even kind of protrude into the cavity of the uterus here. And then we can also have growths on the fundus of the uterus as well. Then we have the meningioma. This is going to be a tumor that develops within the meninges. So you can see those also can be within several different places, and we name that based on the location. And this is just a MRI that is giving you several different sections of where that meningioma is found. And let's move into malignant tumors here. These are named according to the cell type from which they arise. So we see that we've got carcinoma. So any type of carcinoma is going to develop from epithelial tissue. So in the case when we are developing that tumor within the skin, we see that the cell type there is squamous. Therefore, we call it squamous cell carcinoma. And you could see examples of what that would look like here on the right. And then we have adenocarcinoma. So anytime we see that term adeno, we want to think gland, right? Think of adenoids, which are glands, right? There are tonsils. So adenocarcinoma is going to be a tumor that is found within a duct or glandular tissue. So you can see an example of that taking place over here within the glands of the colon. And this is an adenocarcinoma here that is pictured. And I really like this image because it kind of shows you some of the features to look for in cancer cells, the high ratio between the nucleus and the cytoplasm, or sometimes we have many nuclei within one cell, or a really prominent nucleoli. And then anytime we see this term sarcoma, sarcoma is really referring to the soft tissues. And so most of that is going to be a connective tissue, which arises from mesenchymal cells or mesenchymal tissue. And so we can find this within bone, within muscle. So you see some of those examples over here. And when we see that term lymphoma, we want to understand that we're going to find the tumors within our lymphatic tissue. So we know one of the most prominent areas that we are going to have those lymph nodes is in the area of the neck or the cervical region, the axilla, and the inguinal region. Maybe you can already gather that within lymphomas, lymph here is referring to our lymphocytes, which are B and T cells, and they are going to grow or increase in number rapidly. And because we have access to our lymph nodes and lymphatic system, of course, this cancer can travel to other areas in the body. The main difference between non-Hodgkin lymphoma and Hodgkin lymphoma is going to be that there's the presence of these Reed-Sternberg cells. So we're going to talk more about this when we get into our lecture on the blood. And then lastly here we have leukemia, which also has to do with our blood cells. And if you remember leuko, that term means white, right? So that is going to refer to our white blood cells. And in this case, we have an increase in white blood cells within our blood. Now, you may have also heard of the term carcinoma in situ. So I always think in situ, think of like in situation or in the tissue. And so when we see this term, it lets us know that the cancer is in its early stages and is a pre-invasive epithelial tumor. Remember, carcinoma, when we see that, is referring to epithelial tissue. And this could be of our glandular or squamous cell origins. So at this point, we haven't broken through the basement membrane. That is the key phrase here when it comes to in situ. It's still within that main tissue area. So you can kind of see these situations here, in situ situations, where the cells are located just within that tissue. Here's the basement membrane in the gray, right? So once it moves through that basement membrane, that is when it becomes invasive. But if those cells just stay within that area, then it's kind of a stable type of tumor that we have going on, and it could regress and disappear, especially with treatment. So, but like we said, if we pass that basement membrane, it becomes invasive. And down here, we see an example of this when it comes to the uterine cervix. So we're taking a look at this normal epithelium at first, and then we start to see this low-grade intraepithelial neoplasia that starts to develop, where we are starting to see some of the loss of the normal tissue architecture here, and this is signifying for us that there's a development of cancer taking place. That then can progress to this high-grade intraepithelial neoplasia. Now you could see here that we still have that basement membrane intact, but then once it moves past that area, this is when it's an invasive carcinoma, and we have a high rate of cell division taking place, a presence of local mutagens and inflammatory mediators that are contributing to an accumulation of genetic abnormalities that are leading to this cancer development. So as a review, which of the following statements is true? A, all neoplasms are cancerous. B, benign growths are cancerous. C, malignant tumors have slow growth. D, cancer refers to a malignant tumor. What do we think? If your answer is D, you are correct. So cancer is going to refer to a malignant tumor, whereas our benign growths or tumors are not invasive and are not cancerous. The malignant tumors are going to have rapid growth, and our neoplasms may be benign or cancerous. All right, let's talk about the biology of cancer cells. If you don't know this yet, surprise, cancer is complex, as you're going to see as we move through this lecture. So a tumor is going to be a heterogeneous mixture of cells. So we'll have some cancerous cells and some that are benign. And there are three major stages of cancer development. We first have initiation, in which we're starting to see an initial mutation taking place. Some type of damage to the DNA takes place. Now, is that through radiation, UV light? Is it from chemicals? It doesn't matter, right? There's some type of damage to the DNA. The next stage is going to be promotion, where we're going to have clonal expansion. So see that word clone in there, right? So we're going to have those mutated cells start to become stimulated and divide. And this is an unregulated, accelerated type of growth. Then we've got the last stage, which is progression. Here, the tumor cells compete with one another and develop even more mutations, and this makes them more aggressive, and it can more easily kind of go under the radar from our immune system, especially our adaptive immune system, from being able to identify them and kill them or cause them to apoptose. Now, in the previous slide, we talked about the initiation of a mutation, but really multiple mutations are required before a cancer can really develop. There's driver mutations that drive progression of the cancer, and after a critical number of driver mutations, the cell becomes cancerous. Now, depending on the type of driver we have, we may have clonal proliferation or expansion taking place. So when we have these drivers, they are given a selective growth advantage. So they are going to promote cancer development. So that's when, again, we use that term driver mutation. And those that do not carry on those mutations that are going to make the cell cancerous, we term those as passenger mutations. So you see that over here where they're not making as big of an impact, let's say, to allow the cells to continue and divide and all of that to cause cancer. So you could see some weak drivers here that are allowed to kind of still stick around. And so what that does is causes the mutations that kind of give it an advantage in order for it to be able to increase its growth rate and decrease its programmed cell death, its apoptosis, whether it's the cell itself or other cells within our immune system kind of triggering it to go through apoptosis. So we'll talk about more of that in just a little bit. Next, we're going to talk about the hallmarks of cancer, and there are a ton of them listed here around this wheel. So we are going to go into detail regarding some of these in the coming slides. But primarily it's going to be due to genomic alterations. So having sustained proliferative signaling, evading growth suppression, and genomic instability and replicative immortality. These cells are meant to only survive for a certain amount of time. So once they get that signal that, hey, you don't need to die, and they have mutations or things wrong with them and they're able to rapidly grow, that becomes a problem, right? And then secondary to these genomic alterations is angiogenesis, where we are going to get new blood vessel formation. You can kind of see that progression taking place here, because as these cells are rapidly dividing, they're all going to need nutrients. They're going to need oxygen to survive and kind of thrive. So the body sets up blood supply to it, and then also reprogramming energy metabolism. And again, we'll elaborate on this in the coming slides. One of the other keys to these cancer cells surviving is tumor resistance to destruction. We just mentioned this about 2 slides ago, that they can have a resistance to apoptosis. These cells live a certain number of days or months, and then they are supposed to self-destruct. And sometimes they have their own signaling that allows them to do this, and other times it's our immune system that will trigger it to go through apoptosis. But we'll talk more about the pathways in just a bit. And this cancer cell resists that, so that it kind of pushes it more to this immortal type of cell that just continues to divide and live. And our tumor promoting inflammation can take place, and it kind of evades our immune system. Our immune system isn't able to destroy the cancer cell, and it has a couple of tricks up its sleeve to kind of go underneath the radar. And then we have culmination of other hallmarks, such as activating invasion and metastasis. So let's first talk about that sustained proliferative signaling. So this is the foremost hallmark of cancer, is where we get that uncontrolled cell growth taking place. Our normal cells do have proliferative phases when we have growth factors being secreted. So this is just a normal, normal life of a cell. We have these proto-oncogenes, and these are just our genes that direct our normal cellular proliferation. So you may have heard of this onco term and how it always refers to cancer. The reason it was named this is because it has the possibility to become cancer, right? So the proto part here means that it's normal, but it can turn on cancer if there is some type of mutation that takes place and they can work incorrectly. So like we said, growth factors are important here. We need them, but we don't want them to be secreted continuously. Otherwise, it's causing uncontrolled growth. Our growth factor receptors can also supplement with this, our cell cycle proteins, and of course those apoptosis inhibitors that we mentioned in the previous slide. So when they mutate, whether it's the receptors, the proteins, the inhibitors, they can turn into oncogenes. So let's talk about that next. And actually, we kind of see that in this picture where we get the uncontrolled growth from it. But the oncogenes are these mutated or overexpressed proto-oncogenes that cause uncontrolled cell growth. And through cancer research, we do know of some of these. We know RAS and the Philadelphia chromosome and the HER2 that we're going to talk about a little bit more on the next slide. First, I want to tell you about autocrine stimulation. Now, we talked about this in our endocrine lectures in A&P. Auto means self, right? So the cell is secreting substances that is going to work on itself. So the ability of cancer cells can secrete the growth factors themselves and stimulate their own growth. So they can do something like we see here, where the complement proteins are being secreted that are going to stimulate the tumor growth upon activation. So here they're attaching to the receptors, becoming activated, and that is going to cause proliferation. And so in patients with ovarian or lung cancer, we tend to see higher higher tumoral C3 and C5, like we see in the photo over here, mRNA levels that are associated with decreased overall survival. So these data are going to identify a role for our tumor-derived complement proteins in promoting tumor growth. And so now we have substantial clinical and therapeutic implications in which we can utilize what we know about these complement proteins to create treatments. So when we have oncogene activation, we have some type of mutation that is taking place. So this image here is showing us a point mutation of the RAS gene that's converting from regulated to unregulated. RAS, by the way, stands for rat sarcoma, which is where it was found originally. And so when we look at this image over here, we see an active RAS is associated with our GDP, and RAS's job, once activated, is to tell the cell to continually divide. So we get cell growth. That's the big overall picture. And what we see is that up to 1/3 of all cancers have this activating mutation in the RAS gene. And that, of course, is leading to the uncontrollable cell growth. And this is especially true for pancreatic and colorectal cancers. Another example of an oncogene activation is HER2. HER stands for the human epidermal growth factor receptor 2, and that is amplified about 30% of all breast cancers. And so the chromosome changes to produce more copies of the growth factor receptor in those cases. And I'm sure you've heard that HER2 is associated with the breast cancers, and we'll talk about the 4 different forms of that toward the end of this lecture. Now note that RAS is not the only growth factor signaling or growth factor receptor that we have that can be mutated to cause cancer. We've also got our PI3K, we've got our MYC, and the D cyclins as well. These are oncoproteins that can be activated by the mutations and cause cell proliferation. We do have some proteins that are going to help us to inhibit RAS from causing cell growth, and that would be GAP or GAP, which stands for GTPase activating protein, and also the P10 that we see over here. So that is kind of our stop sign for RAS. So within oncogene activation, we can also have translocations contribute to cell growth. And so the translocation can cause an excess and inappropriate production of a proliferation factor. So our first example of this is going to be Burkitt lymphoma, and you could see an image of this taking place down over here. This is when we have a chromosome that takes a piece of chromosome 8 and fuses it with a piece on chromosome 14 here. And so this piece is going to be the MYC oncogene, and normally this is activated at low levels, and it is going to help with proliferating lymphocytes and actually becomes inactivated in mature lymphocytes. But when we have this translocation take place, it causes this MYC oncogene to now become expressed at high levels, and that is because of the direction of the Ig gene right above it here. And so we get a hyperproduction of the MYC protein, and it drives the proliferation and blocks differentiation from taking place. So this lymphoma is an aggressive cancer of the B lymphocytes because of this translocation. The other example that we have is when we get production of novel proteins with growth promoting properties. So our example is the chronic myelogenous leukemia. And this translocation takes place between chromosome 9 and 22 and was first identified in Philadelphia in 1960. And so it's often referred to as the Philadelphia chromosome. And it's where the two pieces of the chromosomes are fused together. So we can see the bottom here of chromosome 9 and the top here of chromosome 22 are coming together. And so the result is this production of what we call a BCR ABL fusion, and this causes an unregulated protein tyrosine kinase that is going to promote growth of myeloid cells. If you remember, our myeloid stem cells help produce some white blood cells, and so we have a high amount of white blood cells within leukemia, and because the protein tyrosine kinase is affected here, causing the uncontrolled growth of our myeloid cells, we have the drugs such as imatinib and related tyrosine kinase inhibitors that are highly effective in order to treat this form of leukemia. And we mentioned evading growth suppressors. We just talked about how oncogenes are activated in cancers, but also our tumor suppressors have to be inactivated to allow cancer to take place. So we have 2 copies of each tumor suppressor gene, and one comes from each parent. And both of these copies have to be inactivated in order for cancer to take place. So how do they function normally? We have an example here of P53. If you've learned anything about cancer, that probably sounds familiar to you. So when we get a cell that has DNA damage or cell cycle abnormalities or is suffering from hypoxia, then P53 is called upon. We stop the cell cycle. We've got DNA repair that can take place, and then the cell cycle can restart. Or if we are, let's say, not going to be able to repair that DNA, we tell that cell to go through apoptosis, right? That kind of stops the cell from continuing on in its mutated form. But when we have a mutated P53, then when we get these situations taking place, here's our mutated P53. The cell cycle is going to continue, and now the cells are going to become cancerous. They're going to continue in their cell cycle and continue to divide with the same mistakes, mutations, DNA damage, continuing on and on and on. So what these tumor suppressor genes are doing is regulating that cell cycle. They're inhibiting proliferation. They're stopping the cell divisions if the cells are damaged somehow, and preventing mutations, especially from being carried on into their daughter cells, right? So anytime these tumor suppressor genes are mutated and are not functioning correctly, they are going to allow cell division to take place. So here's a nice little image that kind of depicts what I talked about earlier with, let's use, for example, our tumor protein P53 that we mentioned in the previous slide, where we're going to have the mutation taking place not only in one of the copies here, but we also need the second one to take place in order for us to allow the cell cycle to continue with the abnormalities leading to cancer. Now, if we have a single germ cell mutation with a sperm or egg cell, that can result in transmission of cancer-causing genes. And this can lead to families with high risk for specific cancers, meaning that only a single additional mutation needs to take place in any other cell, meaning a somatic cell mutation, in order to inactivate the tumor suppressor gene. So let's say we have mutations take place and now our P53 is not working. P53 has also been called the guardian of the genome, and like we saw in the previous slide, it kind of monitors any type of intracellular signals that are related to stress that can activate what we call caretaker genes. And we're going to talk about this more on the next slide, about these caretaker genes. But essentially, they're genes that are responsible for maintaining our genomic integrity. And so it's supposed to, P53 is supposed to stop cell division in order to control the proliferation of damaged cells. Now, we haven't talked about our retinoblastoma or RB gene yet. This is also going to be a tumor suppressor gene, and it resides on chromosome number 13, and it is monitoring anti-growth cellular signals and blocks activation of the growth or division phase within the cell cycle. So if we have a mutation to RB gene, that can lead to persistent cell growth. It's not blocking that activation of the growth phase, so it will continue to allow proliferation to take place. Next, let's talk a little bit more about genomic instability. This is an increased tendency for genomic mutations during the life cycle of a cell, which of course is going to increase our risk for cancer. Now let's revisit P53 once again. We see that something is causing damage to the cell, whether it's ionizing radiation, carcinogens, or mutagens. And we now know this cell has sustained DNA damage. So then our P53 is going to accumulate because of this oncogenic stress, and it is going to bind to DNA. Now we can have a couple things take place from this point on. We can have the cell become arrested in G1 by upregulating the cell cycle inhibitor P21, or we can also try to repair that DNA. So if that works, then we are able to successfully repair that DNA and we get our normal cells that can divide and continue on. If the repair fails, then we are going to signal through Bax that we want the cell to go through apoptosis, or the other route we can go through is we send the cell into senescence. Now what this means is the cell does not die, but the cell is just going to kind of age, but permanently is going to stop dividing, so that we are not going to carry on that DNA damage, that mutation to future cells. And through these mechanisms, we are not going to give rise to any malignant neoplasms. Now, in the other case, we have a cell with mutations or a loss of P53. And there's a ton of different ways that we could put the cell under stress, right? In which normal P53 is able to detect. Examples would be anoxia, oncogene expression, nuclear damage, and all of these will signal to us that we've got some type of cellular abnormality taking place. But when we lose P53 and we do have that DNA damage take place, then we don't have P53 to activate the pathways that we saw on this left side here. So our cell cycle is not arrested, DNA is not repaired, and the cell is not sent into senescence. So the mutated cells instead are going to go through expansion, and we might even have some additional mutations taking place as we continually divide, and so that will divide into a malignant tumor. I just have to say I love the illustrator's use of the happy face here with P53 working functionally, and here where it's sad when we lose P53, and then look at all the evil scary faces here with the malignant tumor. Just done so well. So as a reminder, when we have genomic instability, we're referring to an increased tendency of alterations or the mutability in the genome during its life cycle. And so this can result from increased epigenetic silencing or modulation of gene functioning, where we have these promoter regions of our genes becoming altered and leading to either silencing or altered gene expression. So you could see here where things are normal, we are having transcription, we get our mRNA, and that leads to a protein. But what we can have is some inherited mutations can threaten the integrity of an entire chromosome. So for example, we have Bloom syndrome, in which we have mutations in DNA helicase, or that can present with an increased risk of several forms of cancer. Other times we can have things like increased methylation of DNA in the promoter region, like we see taking place over here, and they can have associated changes with our histone modification as well. So you could see that taking place over here, and these changes result in an alteration within the promoter region of our genes, and that is silencing or altering the gene expression. So that is why we do not see transcription taking place. It's inhibited and no protein being made in the end here. So when we have chromosome instability, which is depicted over here, we have increased chances of developing malignant cancers, and it results in chromosome loss or loss of heterozygosity and chromosome amplification. One of the other hallmarks of cancer we talked about is replicative immortality. And so our normal body cells, like we said, are not immortal. They have a certain lifespan that they're supposed to kind of live out and then go through apoptosis or another form of dying. So they can only divide a limited number of times. And at the very end of our chromosomes, we have these things called telomeres. You can see it pictured over here. And our telomeres are protective ends or caps of repeating hexanucleotides, meaning 6 nucleotide units on each of these chromosomes. So most of our normal cells, every time they divide, we do take a piece of these telomeres off. So we can kind of have an idea of, let's say, somebody's age based on the length of their telomeres. And so this idea is known as the Hayflick limit. And this is Hayflick over here who discovered this. Once we reach a certain length and we've kind of gone through the number of times that the cell is supposed to divide, then the cell, like we said, can either go through apoptosis or it can even go into senescence, where it doesn't die, but it just permanently stops dividing. Now, in some cases, we want a cell to continue to divide. We don't want it to die. We don't want it to stop dividing. And so to maintain or hold these telomeres in place, we use an enzyme known as telomerase. And this is usually only active in germ or stem cells. And by germ cells, I'm talking about within the ovaries or the testes. So when our telomerase in cancer cells are activated or switched on, they are going to continue to allow these normal adult cells to continue to divide. And so the telomerase enzyme is going to help to rebuild these telomeres, just like the germ cells. So in that way, these cancer cells become immortal. So this slide is just a continuation of the previous one, where our cancer cells are showing immortality. In this image on the right-hand side, we are seeing that this mouse has prostate cancer. The telomerase enzyme is active, and so we are getting some telomere dysfunction in which the cells are dividing, but the telomeres are not shortening. So they're going to continue to allow the cell to divide. However, in this case, we've got aggressive prostate cancer with bone metastasis, and we are seeing active telomerase here too, and we've got our telomere stabilization. So you could see that the ends are quite long on here because those telomeres are not being shortened every time the cell divides. And so what they found is that telomerase activity has been restored or activated in about 90% of all cancers. Another way in which tumors can sustain themselves is through angiogenesis. So angio, I kind of think of arteries, and Genesis, think new, right? So we're getting a growth of our new blood vessels, and this is essential in the tissue undergoing repair within our body and is essential to the growth and spread of cancer. As I mentioned in the beginning of this lecture, these cells are rapidly dividing. And so as they are being developed, these cells are going to need blood supply. There's only so many resources for these cells. So a signal is sent saying, I'm starving, and it signals for a new blood vessel to be grown. And so this could be done through pro-angiogenic factors. You could see some of these here being secreted by the tumors, such as VEGF. This stands for vascular endothelial growth factor, and also things like our BFGF, which stands for our basic fibroblast growth factor, and PDGF, which stands for our platelet-derived growth factor. And it is going to attach to its receptors, of course. The other thing that we'll see secreted are tissue remodeling matrix metalloproteinases, or MMPs, that are going to actively induce the formation of these new blood vessels. Now, how do they get created? We are going to recruit some local endothelial cells and some of the circulating precursor cells and some platelets, so that we can grow these blood vessels to bring in blood supply. Another way in which cancer cells can thrive is by reprogramming energy metabolism. So normal somatic cells, or non-malignant cells, let's say, are going to be able to get the oxygen they need by producing ATP. And this is done through the mitochondria through oxidative phosphorylation. And we get to generate 36 ATP through each glucose molecule that comes its way. So we see that process taking place over here. This is probably the most efficient way to get our energy, our ATP. And when normal cells are experiencing hypoxia, then they're going to perform glycolysis, or the breakdown of this glucose molecule, and we still get our ATP, and this process is called anaerobic glycolysis. Anaerobic referring to without oxygen. We get our 2 ATP through this process per glucose molecule. Now, in the 1920s, Otto Warburg was the first to notice that there is a difference between our normal cells and what we now know as our cancer cells. He came up with the Warburg effect and noticed that even if we have enough oxygen present, cancer cells produce their ATP through glycolysis instead of going through the normal oxidative phosphorylation process. So you can kind of see that taking place over here, where we've got our glucose, and instead we go through what is going to be called aerobic glycolysis. And this allows lactate as a byproduct to be produced, and he thought that the cancer cells would use this for production of lipids, nucleosides, amino acids, and other molecular building blocks that we would need in order for these cancer cells to rapidly grow. Now, decades later, many believe the reverse Warburg effect, in which they believe that by inducing oxidative stress, they are forced to undergo this aerobic glycolysis process in order to produce our metabolites here, like lactate or pyruvate, and the cancer cells can use that within the citric acid cycle, or the Krebs cycle. And here's the Krebs cycle, where you see pyruvate would kind of feed in through this. And their thought was, by going through this process, then it's going to feed into the oxidative phosphorylation process in order to produce ATP. And this may also manipulate the cancer-associated fibroblasts, or CAFs, which would help to release materials that is needed by the cancer cell in order to make some new organelles for the dividing cells. So researchers believe that the cancer cells are reprogramming their metabolism in order to deregulate proliferation, be able to withstand the oxygen and nutrient challenges they might have to endure, remain de-differentiated with alterations in their gene expression, withholding those mutations, and corrupt surrounding microenvironment to assist with tumor growth. Another way that cancer cells can survive and thrive is through resisting apoptotic cell death. We know that apoptosis is programmed cell death, and they basically self-destruct. So we have defects that can take place in either the intrinsic pathway and the extrinsic pathway that will cause a cell to go through apoptosis. Just as a reminder, the intrinsic pathway is also known as the mitochondrial pathway, where we're monitoring cellular stress. So this could be through DNA damage, it could be genomic instability, growth factor withdrawal, free radicals that can cause damage, and so forth. And so through that, we, if we do have any type of cellular injury here, we are going to involve some proteases, which are called caspases. And essentially what they are going to do is cause the breakdown of essentially the organelles. The extrinsic pathway is going to work by way of receptors on the plasma membrane. So these receptors are known as the death receptor. And when we have the receptor activated, that is going to get these caspases to also cause a breakdown of our organelles. And one of P53's goals or jobs is to activate this apoptosis process when there is any type of injury that takes place to the cell. So if we have a mutation within our P53 gene, that is going to suppress the activation of apoptosis. And there are also other mechanisms that can cause resistance to apoptosis, such as having a downregulation of the caspases or a production of caspase inhibitors so that we can't activate them to break down the cell and cause apoptosis. We can also have cancer cells take advantage of the inflammatory response. It could become manipulated throughout the process and benefit tumor progression and spread. Now, in the previous chapter, we talked about how chronic inflammations are going to increase the risk of cancer development, and it could result from many different causes, such as solar irradiation, asbestos exposure, pancreatitis, and infection. And we also know that certain organs are going to be more susceptible to oncogenic effects of inflammation. You can look at table 11.3 to see a list of these, but some of them are going to include our gastrointestinal tract, our prostate gland, and the thyroid gland. An example of this would be people who suffered from ulcerative colitis for, let's say, 11 years or more and have up to a 30-fold increase in the risk of developing colon cancer. Another example is having chronic exposure to asbestos, and that is going to lead to mesothelioma, which is a lung carcinoma. And we can also have infective agents that can cause cancer. We also previously talked about HIV and how it can lead to certain cancers such as non-Hodgkin lymphoma, squamous cell carcinomas, or Kaposi sarcoma. People who are infected with hepatitis B or C might be more prone to our hepatocellular carcinoma. And then we've got the example up on screen here, which is Helicobacter pylori, which is a bacterium that could cause gastric inflammation that is induced by the infection of H. pylori here, and that is going to infect actually about more than half of the world's population. And so this can be associated with things such as peptic ulcer disease, stomach carcinoma, also known as gastric adenocarcinoma, and what we call MALT lymphoma, which is less common. And MALT, if you remember, stands for mucosa-associated lymphoid tissue. And it does this by directly and indirectly producing genetic and epigenetic changes in the cells within the stomach, which includes mutations to our P53. So when cancers develop too, it starts to disrupt the environment it is within, and it can initiate or even enhance inflammation that has already taken place, and in turn start to recruit some local and distant cells. That would include our macrophages, maybe some lymphocytes, and some other cellular components of inflammation, such as our complement proteins or something like that. So most tumors are going to have a large number of what we call TAMs, or tumor-associated macrophages. These are going to promote the tumor's survival. When we find them present, they do worsen the prognosis of that cancer, and they tend to mimic what we call an M2 phenotype. This is when the monocytes are attracted from the blood into the tumor, and they mature into macrophages within this M2 phenotype, meaning they're going to produce anti-inflammatory mediators to suppress ongoing inflammation and induce cellular proliferation, angiogenesis, and wound healing. Another feature is that they develop the capacity to block our T cytotoxic cells and the NK cells. Remember, those two cells are going to function to kill cancer cells, right? And so they start to produce cytokines that are advantageous for tumor growth and spread. So I like this image on the right hand side here so you can see some of the effects that we discussed. Note that we've got our VEGF that is being secreted from the TAMs in order to cause angiogenesis to take place and increase oxygen to the tumor cells. Another way that we're going to continue growth is by evading immune destruction. Our normal immune system helps us to protect ourselves against cancer. So let's quickly walk through how our body does this before we discuss how cancer cells are evading this. So we typically are going to have the tumor cell or an antigen presenting cell take a piece of this tumor's antigen, our tumor associated antigen. So these could be products of the oncogene. It could be antigens from oncogenic viruses, such as human papillomavirus. It could be an oncofetal antigen that is usually expressed within our embryonic tissues and our tumors, and it displays it on its MHC here. Our T cells, this one happens to be, I believe, a cytotoxic T cell, has its TCR, T cell receptor, attach and say, hey, this antigen is foreign and I need to become activated, and go through clonal expansion. And so we clone that activated T cell and find these tumor cells and release granzymes and perforins to allow it to move into the tumor cell, causing the cell to die through lysis. Now, through immunotherapy, we can predict that our immune system can be used to target these specific antigens that we find and destroy the tumors clinically. We can either do this through immunization with our tumor antigens to enhance our immune response to these tumor cells, or we could do it passively by injecting the person with cancer with the antibodies or the lymphocytes directed against the tumor antigens. So like we discussed in the previous slide, we want our T cells to kill these tumor cells, but we have our cancer cells create these tumor infiltrating lymphocytes, or TILs, and this is a way in which the cancers are actively recruiting the immune response. They are getting them to remodel the tissues and form new blood vessels for them and promote metastasis. And so it's kind of like they're getting our lymphocytes to switch teams. And the ones that tend to switch teams and become kind of the bad lymphocytes are our T regulatory cells. These are CD4 cells, and they're supposed to protect our own tissues against autoimmune reactions. Remember, they're the ones with the stop sign saying stop, we don't need to attack anymore, and everything kind of goes back to homeostasis, hopefully. But at this point, our tumor is manipulating it to prevent a destructive anti-tumor immune response, and it provides cytokines that can facilitate tumor cell proliferation and spread. IL-10 is one of these, where it's going to decrease Th1 and Th2 activity and suppress that antigen recognition that we want to take place. So you could see some of those methods in this figure over here, where we're not recognizing the antigen, we have a lack of T cell recognition of the tumor and inhibition of T cell activation. Now, how do we activate a benign tumor to go through the process of invasion and metastasis? So we have local spread that is going to start to evade the tissues around it and cause metastasis. And in order for this to take place, we need to recruit TAMs. Remember, that stands for tumor-associated macrophages. And we can also use other stromal cells in order to secrete proteases and protease activators, such as the MMPs that I mentioned before and the plasminogen activators. And this helps to digest some of the connective tissue that surrounds it in that capsule, and so we now have no structural barrier to keep these cells intact, and the cells can start to spread into its environment. Remember, we said the word cancer means crab. Doesn't this kind of look like legs of a crab? So bringing it full circle here. And so with having some of the other cells being able to now move away from the origin, typically those cells on their own in a different environment should start to die. They should go through apoptosis. But tumor cells have resistance to apoptosis, so they are able to travel and survive, and then essentially is going through the process of metastasis and spreading to secondary sites which are distant from the origin. So changes to in the tumor microenvironment are going to cause these cancer cells to evolve. And with this evolution, they may create multiple new abilities. And so we are next going to talk about epithelial mesenchymal transition that these cells go through. So this epithelial mesenchymal transition, or EMT, is normally a process that takes place through embryonic development, as well as through wound healing and tissue repair. So cells that were epithelial cells will actually transition and become mesenchymal cells, which, if you remember from talking about histology, mesenchymal cells, I always say, are kind of like your inner 5-year-old. You can become anything you'd like to be, right? So what we start to see is that the epithelial characteristics are lost. We see increased migratory capacity, increased resistance to apoptosis, and dedifferentiated stem cell-like state. Again, they can turn into different types of cells. So growth is favored in foreign microenvironments because they're like, oh, this is just a stem cell. They are supposed to be dividing like crazy. And just a fun fact that IL, or interleukin 8, is an effective driver of carcinoma cells into this EMT transition. Now we're going to dive into some clinical manifestations of cancer, one of them being paraneoplastic syndromes. Now this syndrome is due to symptoms that are triggered by cancer, and these are due to biological substances that are released from the tumor, such as hormones or cytokines. They could also be due to an immune response to the tumor and are not caused by direct local effects of a tumor. So they tend to be the earliest symptoms for someone that does not know that they have cancer. There is a great table 11.4, that gives you the classifications. And I also have some symptoms in this figure over here for you. But just as an example, we have some carcinoid tumors that can release substances that would include things like serotonin that could move into the bloodstream that could cause things like flushing or diarrhea or wheezing and a rapid heartbeat. Another example are certain cancers that are going to trigger an antibody response. So going back to this immune response to a tumor that can attack the nervous system, and that could cause a variety of neurologic disorders. Another manifestation is cachexia, and this is when we have a energy balance disorder where the energy intake is decreased, but the energy expenditure is increased. And so again, it's an unbalance of this energy. And by having this imbalance, we are going to affect multiple organs, and it is known as an energy wasting syndrome because we are putting more out than we are keeping in as far as our energy levels. And the most severe form is malnutrition, and that's going to contribute to two common factors that we see within cachexia, and that's going to be weight loss that is mainly from our skeletal muscles. So we tend to see muscle weakness and fatigue, and this is related to a loss in the myofibril proteins within the muscle cells. And the second common factor is going to be body fat loss and inflammation taking place. So this would be related to having our white adipose tissue loss caused by, like we said, altered metabolism. So we're going to have increased lipolysis. We'll have a decrease within the lipoprotein lipase, or LPL, and a decrease in new or de novo lipogenesis within the adipose tissue. And we'll also see that we've got both orexigenic or appetite stimulating and anorexigenic or appetite suppressing brain pathways that become profoundly altered. Often this is irreversible and it affects about 50 to 80% of people with cancer. Next, let's talk about cancer staging. So typically we want to use microscopic analysis for staging, and it's based on the presence of metastasis. So in general, we use a 4-stage system with carcinoma in situ regarded within special cases. Like we said, we discuss in situ when it hasn't broken that basement membrane. So we'll start with stage 1. That is going to be when we see that the cancer is confined to the organ of origin. Stage 2 is going to be when the cancer is invasive locally. Stage 3, we see that the cancer has spread to regional structures such as the lymph nodes. And stage 4 is when we have distant metastasis. So, for example, a liver cancer has spread to the lungs, or a prostate cancer has spread to the bone. Another way to classify cancer was done through the World Health Organization, and it's known as the TNM system, where the letters are standing for different things, of course. So T is for tumor spread. We can see here 0, of course, is that there is no tumor. 1, you see that it is located within the organ here. 2, it is a larger tumor. And 3, we have surpassed through the skin or the chest wall by invasion. And then is referring to node, such as our lymph nodes. Are they involved? So 0, of course, is they are not. Stage 1 here is going to be when we have that lymph node involved, and stage 2 is that the tumor is fixed in multiple lymph nodes here. Then M is for metastasis, distant metastasis, really. So within stage 0, we see that there's no metastasis. Stage 1, there is metastasis that has taken place. So if the cancer is in the breast, then it has spread into the liver. And then stage 2, we have suspected metastasis. So we see that it may possibly have gone to different sites, such as the lung or the bone. Question 2 here for you. A patient has been diagnosed with prostate cancer that has metastasized to the bone. The stage of this cancer is, do we think it's 1, 2, 3, or 4? If you said 4, you are correct. The cancer has spread to a distant site, such as liver cancer spreading to the lung or prostate cancer spreading to the bone, is always going to be a stage 4. Remember that when we have cancer confined to its origin, it's stage 1. If cancer is locally invasive, it's stage 2. And if that cancer has spread to regional structures such as the lymph nodes, it will be stage 3. Next, let's talk about tumor markers. These are known as biochemical markers and can be produced by both benign and malignant tumors. we are going to have them produced by our cancer cells, and they could be found on the tumor cells, within our blood, our cerebrospinal fluid, or the urine. And things that can serve as these tumor markers could be hormones, enzymes, genes, antigens, or antibodies. If you look at table 11.7, you'll see some examples of the tumor markers, but I'll just mention one real quick here. Our marker could be just our ACTH that we already know, adrenocorticotropic hormone. Of course, we need a specific level of that, or the alpha fetoprotein, AFP, and that is going to be a peptide hormone. And if we see those elevated beyond normal, it is basically letting us know that we have a pituitary adenoma, or it could be a tumor within the liver or our germ cells. So what can we use these tumor markers for? We can use them to screen and identify individuals that are at high risk for cancers. We can diagnose for certain tumors and observe for clinical courses in cancer. Now, unfortunately, we can get false positives and negatives. For example, men who are ages 55 to 69 years old are screened to see what their PSA levels are. PSA stands for prostate specific antigen, which is a blood test to see what your PSA levels are. And essentially, you're going to use those levels to screen for prostate cancer. If you screen a patient and they have a level above 10, then there's a greater chance that they may have prostate cancer. Tumors can also be classified based on their immunohistochemical analysis of their protein expression. This is supplemented by a more extensive genetic analysis of tumors, and its enhanced molecular characterization subdivides the cancers into therapeutically and prognostically relevant smaller groups. So it helps to give improved treatment and more personalized medicine. For instance, breast cancer have 4 different types that respond to therapy differently. So this could be really helpful in cancer treatment. So we're going to talk about cancer treatment next. The classic approaches are surgery. That is often the definitive treatment of cancer, and unfortunately can't spread beyond the limits of surgically excising that tumor. There's also chemotherapy, which are drugs that are usually given in combinations designed to attack a cancer from many different weaknesses at the same time and limit the dose. And then we've got radiation therapy, which aim to kill the cancer cells while minimizing damage to the normal structures. We've got immunotherapy. We're going to go into detail on that. And then therapy undergoing rapid evolution, such as genetic analysis of an individual's cancer. So we'll start off going into detail with surgery. Surgery can also be used to prevent cancers, such as colon polyps. We know that you can have a colonoscopy to kind of search for these polyps, right, before they turn cancerous. You may also do genetic testing to kind of look to see if you have certain genes that are mutated. For instance, if you have the BRCA1 gene mutation, which, if you remember, Angelina Jolie has this mutation running within her family, it dramatically raises the risk of cancer of the breast and ovarian cancer. So Jolie did make the decision to undergo a preventative double mastectomy, and sometimes people even decide to have a bilateral salpingo oophorectomy, meaning they're removing the ovaries and the fallopian tubes as well to kind of prevent getting cancer within these regions. Of course, when somebody does have a tumor, they do surgery to remove that tumor. This is just one of those surprising moments where a patient was having no symptoms, but they were doing, I believe, ultrasounds and they were inconclusive, so they decided to go in surgically and discovered a 32-pound tumor that was removed in this man's abdomen, and it seemed that it was affecting only one kidney, surprisingly. You may also go in and do some lymph node sampling, and we've talked about palliative surgery. If a tumor becomes too large and is causing pain, then it could be excised. Then we mentioned radiation already, and the goals are to kill that cancer without extensive toxicity. We can also aim to avoid damage to normal structures. Ionizing radiation is going to damage the cells by imparting just enough energy to cause molecular damage to the cells, and we specifically want to focus on the cancer cell's DNA becoming damaged. So the cellular compartments with rapidly renewing cells will typically damage a lot more easily in this fashion because they are more radio sensitive, and this radiation is typically used in areas that are hard to reach, such as the brain or pelvis, meaning they're hard to reach surgically, that is. And there's many different methods in which that radiation could be done, but the most popular is this external beam. And lastly, I just wanted to quickly mention brachytherapy. This is when they use capsules or seeds to put in body cavities. In this figure, you can see that they're putting them within the prostate, and it is typically used to also treat cervical or head and neck cancers. Now let's talk about chemotherapy. This takes advantage of specific vulnerabilities in our target cancer cells. For example, them rapidly dividing, they're going to have certain processes taking place that our normal body cells are not having take place as much. And it's usually given in a combination so that we can attack the cancer from many different angles in which they could be weak at the same time, as I mentioned before. Now, there are these 3 different types of chemotherapies. First is induction, in which we're trying to shrink or have a disappearance of that tumor. Adjuvant chemotherapy is when we want to eliminate the micrometastasis after surgery. So surgery has been performed and we are trying to get rid of the little bit that may be left over. And then we have neoadjuvant therapy that's given before localized treatment in order to shrink a tumor so that it might be easier to surgically remove that tumor, or we want to shrink it so that we can spare some of the normal tissue surrounding the tumor. Scheduling is also going to be very important in chemotherapy because the cancer can become drug resistant if there are significant delays between the chemotherapy treatments. Also, as I said, a lot of the chemotherapy drugs are targeting rapidly dividing cells, so sometimes we can kill off normal cells that are rapidly dividing that are not cancerous, such as those in the bone marrow. So hematopoietic growth factors have been used in order to counter the effects of this chemotherapy side effect. Also, this is, as a side note, the reason why people going through chemotherapy lose their hair is because our hair is rapidly dividing in order to grow. We discussed immunotherapy a little bit in the previous slides, but essentially we're using the unique antigens that cancer cells have to be targeted by our T cells that are trying to create this immune response to kill them. So our goal is to kind of boost our immune response or convert a tumor protective immune response to a destructive one. So our tumor cell vaccines are pretty effective in protecting against infective agents. We have a couple out for cervical cancer, and then there's numerous potential therapeutic vaccines that have been tested, unfortunately, with little success. Another vaccine to know of is this Provenage, or it's also called Sipuleucel T, for the treatment of metastatic prostate cancer that is resistant to some of the conventional therapies. So you can kind of see the example over here where our antigen presenting cell is presenting the PAP peptide here to our T cell. The T cell then becomes activated and will secrete its granzymes and performs in order to attack the cancer cell. And the way that they prepare this to take place is within the patient that has cancer, they take the dendritic cells and incubate it with a protein resulting from a fusion of prostatic acid phosphatase, which is a cancer antigen found in about 95% of prostate cancers. And then they take the dendritic cells and present the antigen back in the patient so that this process will take place. Now, this has only extended the lives of the patients by approximately 4 months, but those 4 months were very meaningful to those patients. There have also been some other vaccine approaches to B-cell lymphoma and melanoma that have shown promising results, but we do not have enough research and data on those just yet. And lastly, we have targeted disruption. This is done by using the help of chemotherapy, and we use specificity here. So highly specific mutations that are known are utilized to figure out treatment methods. And because they are so specific, it tends to be less toxic to the patient. And here is one of the tables from your book that lists some of these specific drugs. An example would be Anatimib, which is a competitive inhibitor of the tyrosine kinases. And we've talked about this translocation before, where we have the BCR-ABL fusion that took place. And you can see this substrate that's in place causes phosphorylation. And so cellular proliferation would continue there within this chronic myeloid leukemia. However, when we use Anatimib, it's competing with that substrate, and so now that phosphorylation cannot take place and proliferation does not continue. Another example of this targeted disruption would be the use of monoclonal antibodies against the CD20 receptor on our B cell. And this essentially is used to treat B-cell lymphomas. So you can see that our macrophages and natural killer cells or Kupffer cells within the liver can come and essentially cause that B-cell to die. We can have our complement proteins come and assist and create that MAC complex, right? The membrane attack complex, causing it to lyse. Or it can cause direct apoptosis or programmed cell death. So that is it for our Chapter 11 lecture. Please let me know if you have any questions.